So I'll start by introducing Lauren. Lauren Jarmusz is a physical therapist and orthopedic clinical specialist currently practicing at Stanford Healthcare. She is also the co-founder of PhysioCare.io, a hybrid in-person and technology-based service designed to provide primary care for women's movement health. And Lauren is here to talk about chronic low back pain from a physical therapist perspective.
All right, thanks, Sam. All right, so I'm going to share my screen. I'm a newbie at Zoom, so cut me some slack, believe it or not. All right, I believe my screen is sharing here. All right, guys. So today I'm here to talk to you about the physical therapy approach to low back pain. It's more or less a framework of how physical therapists look at low back pain and then how we treat that. It's very hard for me to then put everything I've learned in the last 4 years basically into one PowerPoint. So it's more of a framework and a guidance for other allied healthcare professionals out there so that they know what to do when this crosses their path. And it will cross your path because low back pain is extremely common, and almost 30% of primary care visits have some reports of low back pain in them. All right. So just clearance, I have no potential conflicts or conflicts of interest to report. Okay, so objectives today. So we're going to look at the philosophy and vision of the physical therapy profession. Then where does that profession, where does physical therapy fit into the medical model? We'll take a look at how physical therapists view the human body, or what we like to call the movement system. The PT diagnosis, how we say this is what you have, and then based off of that diagnosis, we'll get into a framework for PT interventions and plans of care. And then finally, we'll get into collaboration efforts so that we know how that other healthcare professionals and other people in the community can help our patients mitigate the low back pain issues. I would like to say that my opinions, when it comes to opinions, are my own. I can't speak for all the physical therapists out there, but I'm doing my very best to give a very comprehensive view of our profession. What are our guiding principles and visions of our physical therapy world? This is from the APTA, or the American Physical Therapy Association. And basically, the physical therapy's profession's greatest calling is to maximize function and minimize disability. We want to, movement is key to optimal living and quality of life for all ages. And that extends beyond health to every person's ability to participate in and contribute to society. So if you can't move, you're probably not going to be that happy. And so it's our job as therapists to make sure you move and stay happy and live a healthy, happy life. A little background that I think would be helpful as I've been talking to other allied health professionals, learning what my scope is as a therapist and what I can do should be helpful. So my degree is a clinical doctorate degree. It's a 3-year graduate program. After undergrad, our scope of practice is quite large in a sense. It states that we have the scope of practice to create a PT diagnosis and prognosis, to optimize physical function, movement, performance, health, quality of life, and well-being across a whole lifespan. Pretty broad. So a couple things that providers may think that we're able to do that we aren't able to do, which will help you understand what my role as a physical therapy is that we're actually not able to prescribe medications or order imaging at this time. All right, another interesting fact about our profession is just like a medical doctor, physical therapists also have specialties. So unlike an MD that's required to go into a residency and specialize, whether it's primary care or cardiology and such, physical therapists aren't required to specialize. They can, but they're not required to. But it is good to know, if you are a provider out there, that we have 10 different board specialties out there. So if you're looking specifically for a patient to go to physical therapy because they had a heart attack and they need cardiac rehab, we do that. But looking for a cardiovascular or pulmonary specialist would probably be your best bet. Similarly, if you have a young kid, looking for a therapist that specializes in pediatrics is a good way to go. Personally, I'm an orthopedic certified specialist, meaning I deal with the aches and pains of everyday life, the knees, the hips, the back. You get surgery, ICU, and such. And so I deal with that on a daily basis. Again, this is just our vision statement. Our goal will transform society by optimizing movement and improve the human performance. All right, so where does physical therapy actually fit into the medical model? So to give us perspective, it's always good to look at current guidelines that are out there. This is from 2017. It's from the American College of Physicians. What are their guidelines for non-invasive treatments for low back pain, acute, subacute, and chronic? What's nice to see is that all their top 3 recommendations basically say there should be some type of conservative management, non-pharmacologic treatment that you use before you go down a pharmacologic route, or even surgery, injections, and such. So that's great. We fit right into that medical model. We're being recognized, and that's excellent to see. All right. Another viewpoint that I wanted to pull up was actually a flow chart from the Department of Veterans Affairs. Overall, it's a beautiful flow chart. I think they did a really nice job trying to standardize a very complicated diagnosis. But there are a couple of points I wanted to point out and maybe show where physical therapy can be optimized in this current flow sheet for medical professionals or physicians specifically. So firstly, up at the top, when a patient comes in with low back pain, it's very, very, very important to screen for a history of red flags. Meaning, is there something that we should be picking up that needs to be treated immediately? Is low back pain masquerading for METs in the spine? Is it masquerading for a kidney dysfunction? Is it masquerading for a AAA? Those are big red flags, and doctors need to screen those. So that's right at the top. It's number 2 step. The important thing I wanted to bring up is that with my clinical doctorate, I also have the ability to screen for those red flags. Now, within my scope of practice, I can't diagnose the red flag, but I should be able to say, this isn't appropriate. You should not be in therapy right now. You should be seeing your medical doctor, or if it's emergent enough, you need to be going to the ED right now. So just wanted to pull out that point. As we move down the flow sheet down to step number 10, that's where physical therapy fits into their flow sheet. It says if you've been having back pain less than 3 months even, you're going to talk about pharmacologic possibly or non-pharmacologic options and make a decision together regarding physical therapy. So that's great. If we look over to module B, basically that moves down from step 16 to 24, much later steps. And all I wanted to point out here was that we're pulled up at number 26, engage patient and multidisciplinary rehabilitation specialist. And what's important about that is, again, I love the flow chart. I think they did an amazing job at it, but we're very late in this flow sheet, and I think we could be a little bit more effective if we're referred to sooner. The following kind of shows that. So sidebar B, again, it's just specific interventions. If a patient comes, their low back pain is acute, less than 4 weeks, what do you do? Those are where those X's are. And if they're subacute or chronic, more than 4 weeks, what are you doing? I would argue, based on our physical therapy literature, that there should be some more X's in the acute or early stages of low back pain. So if we're able to catch a problem earlier, just like any other medical profession, it's much, much easier to treat than if we let this problem linger and manifest itself into chronic issues. So that would be my suggestion there, but this was a great framework of where we're fitting into the current medical models that are out there from some very reliable sources. All right, I'm biased on this model. This is the last model we'll look at in respect to how we fit into the medical system. This was the treatment-based classification system, specifically for patients with low back pain. I'm biased because it was published in a physical therapy journal, and theirs is my favorite model. We're going to focus on the top of this model. So what they basically outlined is a patient comes into the office for the first time. Your first contact healthcare provider, whether it's a nurse practitioner, whether it's a medical doctor, whether it's a yoga instructor even, your patient comes in, your client comes in, they have low back pain. What do you do? So this model suggests, okay, determine the appropriate management approach. Your idea is then to subgroup those patients into 3 different buckets: red, yellow, and green. Red is our medical management. They're really not appropriate for physical therapy right now, or they're at a point where they should see a medical doctor first and then work with a team of providers to address their low back pain. These patients are the ones that have those red flags. Is it a AAA? Is it a kidney dysfunction? Is it METs to the spine? Those are not appropriate patients for physical therapy. They need to receive medical care. Other patients that fall into this red zone or medical management are patients with medical comorbidities precluding rehab, or leg pain with progressive neurological deficits. So anytime we see a progressive neurological decline, they're not appropriate for care. Something else is going on. They need to see a medical doctor at that point. We'll jump to the green box. This is the second subgroup. So now a patient comes in to see you. It's the 20-year-old. They went to the gym. They lifted something heavy, and now they have really isolated and localized low back pain. They're healthy otherwise. They've got a very low psychosocial risk status, and they have no or very minimal and medically controlled comorbidities. Those patients are excellent for self-care management. That's the patient you say, go to yoga, go back to the gym, rest for 4 weeks. Our research shows that patients that fall into that green zone do very well kind of getting better on their own without real specific interventions. So we don't want to over-prescribe either. The yellow area, that's the physical therapist sweet spot. These are the patients that do really, really well in rehab, and we need to see them. So this is the patient who slipped and fell when they're in the grocery store. But now they're afraid to move. They're afraid to move. They're afraid to bend. It's significantly impacting their life. They have a medium to high psychosocial risk status. We need to talk to that patient as a therapist and tell them what's okay, what's not okay, how do we work through this. Another criteria is we also want to see patients with low psychosocial risk status with predominantly leg pain. Basically what that means is it's very difficult just to treat a patient who has psychosocial issues that is catastrophizing, very fearful of all movement, and then the pain is radiating into their whole body. It's not that we don't want to see those types of patients. It means that we need help seeing those type of patients, and maybe we need to pull in a different type of medical provider right now. So ideally, we want to see a patient with low psychosocial risk status with predominantly leg pain. And then finally, the patient who has minor or controlled medical comorbidities. So we want the patients that fall in that yellow zone. There's exceptions to all 3, but if we're trying to provide an objective approach, this is a really nice way to try and do that. Okay, so now you might be saying, great, I like the red, yellow, and green boxes, but is there something out there that I can actually use to appropriately refer patients to if you're coming from a first responder, so to speak, for low back pain? Well, in 2008, this tool was validated actually in the UK. It's called the Start Back Screening Questionnaire, and it was designed for primary care physicians as a quick screening tool. And it helps PCPs make that initial decision by subgrouping the patients based on their prognosis to treat them. So this is what it looks like. It's actually on the computer as well, so you can do this in a more techie fashion, but it's 9 questions. You'll come up with a score, and then based on those 9 questions, you'll be in a low risk, medium risk, or high risk category. Now I overlaid the green, yellow, and red boxes, but this hasn't been directly correlated. So these 2 studies, these 2 formats haven't been officially linked. This is something I've done. It's kind of my opinion, my take on these 2 tools. So the idea would be if they have a low risk, if their score is 3 or less, they're in that low risk category. There's that green zone. They're most likely going to resolve that back pain on their own with time and rest and just getting back into their daily lifestyle routine. If they have a medium risk, basically that's that yellow zone. That's what therapists really want to see. That's where we can make the biggest impact for people to really improve their quality of life. And then if they're that high risk score, basically that's that red zone. Either they really just need to see a medical doctor, or maybe that red zone means that they need a physical therapy, but they also need psychology, they need nutrition, they need a more holistic approach to treat their low back pain. So that's a way as a provider you can figure out who should really be seeing therapy and how we can help them out. All right, so lots of information, big 2 takeaways. If your patients are having low back pain and it hasn't really improved in 3 to 4 weeks, refer to us. We can screen them. If they're still not appropriate, we'll refer them out. And if we think they're appropriate, which many of the times those patients are, we can help them. And then the second takeaway is similar. Don't be afraid to refer to us. A good therapist should have the appropriate knowledge base to screen patients and to send them where they're supposed to be. All right. All right, so now we get to the exciting part. This is my bread and butter. How do we as therapists view the human body? So we view the human body as a movement system. Everything works together. The functional interaction of structures that contribute to the act of moving. As therapists, we take into account the entire movement system, which includes the musculoskeletal system, your muscles, your muscular system, your skeletal system, your nervous system. And we also would take into account the cardiovascular system and even to a slight bit of the endocrine system, because if we don't have the right type of hormonal balance or nutrition or cardiovascular endurance, it's going to affect how we move. So we look at the entire system as therapists. All right, let's look again, bring it back to the low back. So there's 2 different models that a lot of therapists bounce back and forth between. The first model is known as the pathokinesiological approach. The idea behind that is that the pathology caused the movement impairment. A good example of that would be you went over to pick something up, you picked up your daughter, your son, a heavy box, and then because of that, you got a disc herniation, very common. What happens then? You have that disc herniation, you're in pain, you lift poorly, you don't have good engagement of your core stabilization, your legs, you move in very poor movement patternings, and then it perpetuates that pain cycle. So that's a typical approach. I would say, and I can't speak for them, but my opinion is that many medical doctors and nurses think in that way, that you're injured, this is why you have pain, and now you're moving in a funny way. As therapists, many times we like to think in a different framework. We like to think of the kinesiopathological approach. We many times think that the movement impairment can result in pathology. An example of this would be because you're picking up items poorly, because you're not using the right motor control or movement approaches, because you didn't pick up that box the right way, that's what caused your disc herniation. And over time, the human body is very, very sneaky that we move poorly over and over and over and over again. In our body, that becomes our new norm. That's our pattern of movement, and that's what's leading to our injury. The kinesiopathological approach is an approach that Shirley Sharman really harped on, and she is very respected in our field today. So that's a viewpoint that many therapists take. All right. Similarly, we believe in the concept of regional interdependence. Again, this is kind of a coined term, so to speak. Basically, everything is connected. So there are some areas of your body that are supposed to move and some areas of the body that are supposed to be stable, and they're in patterns. And if those patterns or those interactions of sections are altered, it's going to affect everything up and down that chain. So if you had an old ankle injury and now your ankle doesn't move like it's supposed to, maybe that's actually what's causing your knee pain. Or vice versa, maybe your hip lost motion, or you don't have enough strength in your hip muscles and now it's abnormally loading your back. So just the idea that everything is connected. So if you come in to be treated by a therapist for back pain, we will most likely look at your hips, knees, and feet as well, because we want to know what's causing that. So that's those viewpoints, those frameworks are how we work through our subjective and objectives in our evaluation. We take those into account before we come up with our assessment or clinical diagnosis. All right, so looking at our assessment, what is our, gathering all the information from the examination, what do we come up with as an assessment? What is our PT diagnosis? What is going on with the patient? This is really important because just like in any other field, we need to have an evaluation or an examination, it should be. You come up with an assessment or a diagnosis, and then based off of that assessment, you have the right treatment. Your diagnosis is you have a cavity, you get a filling. You have COPD, you do these certain interventions. It's very cause and effect. And if we don't have a right or correct diagnosis, the treatment most likely is going to be off. So nailing that PT diagnosis is really important. What's difficult about the spine, and especially low back pain, is that there's an intimate interplay between lots of moving parts. So getting a diagnosis is very, very challenging. There's a mismatch between movement dysfunction, how people move, anatomical sources of pain, that's that belief of I have a disc herniation, this is what's causing my pain. Many times that is true, so we have to bring in that to account. We have to take into account the stage of patient irritability. Basically, how sore is this patient, and making sure that we don't push them too far too fast. There we go. And then finally, what does the research say about really creating a standardized approach to create this PT diagnosis? Oh, it's moving on its own, sorry guys. So in general, PT can be quite difficult to study. There are a lot of unknown variables in pain science and movement analysis, but I'm really, really proud of our profession. We've been breaking it all down and been able to come up with some very valuable studies to try to objectify a sometimes very subjective-based profession. So I'm very proud of us, and it's very important. All right, so what is in the research, what are therapists using to try to create a framework to create a specific diagnosis for a patient? Once we have that diagnosis, we can treat appropriately. So we have tried very hard to create numerous frameworks. One of them that's out there is known as the Clinical Practice Guidelines for the lumbar spine. It breaks down low back pain into 7 major parts. It could be acute low back pain with mobility deficits, chronic low back pain with movement coordination impairments, acute low back pain with radiating pain. I won't go into all of them. Each of them on their own is probably a separate lecture. But the big takeaway is that we've tried to classify different types of lower back pain. And then we use certain treatment principles to treat those diagnoses. Some of those common treatment principles are therapeutic exercise, neuromuscular reeducation, teaching you how to move again. It might be some soft tissue, or it might just be some patient education. So that is one guideline that we're using as therapists. A second paper out there was done by Dr. Nick Karianis et al. And I'm lucky enough to work with him here at Stanford. And he basically did a review of looking at all the different classification schemas out there for physical therapists to use. So it involves everything from the treatment-based classification, movement system impairments, mechanical diagnosis and treatment. What you really need to know is that they're just different styles or different ways to subgroup patients so that ideally we can provide the best intervention so that patients get better. So what was his conclusion? So on the right-hand side, that's the conclusion to the paper we just saw. Basically, it says that there are a lot of different variations. Predominantly, a biomechanical assessment predominates the majority of the schemes, meaning how people move, the joints, and such. Certain psychosocial aspects are considered in the treatment-based classification scheme. So that one, the diagram I showed you earlier with the 3 different colors, that takes into account psychosocial aspects, which is very, very important. So the paper on the left by Fairbank et al. Basically comes up with the same conclusion, that there are many different schemas out there. No one's necessarily better than the other at this point, but we need to have them as framework. As therapists, we have something to base off our treatment off of. So there's a lot out there. They're all promising, but it's not the end-all be-all. These papers show the exact same thing. All right, so big takeaway. From a PT diagnosis perspective, seeing what's wrong with the patient. There are numerous low back pain classifications for PT diagnosis. There isn't one best practice. So we have to take into account the triad of research, the patient's goals and their expectations, our clinical experience as physical therapists, that plays a big part in low back pain sometimes, as you can see, and then the research behind it, which we're trying to grow over the years. And as therapists, to create a good PT diagnosis or assessment, we have to take into account multiple factors: the biomechanical, how people move, the psychosocial systems, which is a different lecture in itself, but that plays a big role and is linked to a lot of chronic pain issues, and then different comorbidities that can affect a person's system. Okay, this is what I do every day. This is what we do to treat patients. This is our plan of care. So once I used all that research, I used the framework, I used my clinical knowledge, and I came up with a PT assessment. What do I do? And that's kind of where we're going with this. So I took this model actually from a colleague here at Stanford Healthcare, an excellent therapist. Love working with him, Dr. Michael Jean Favre, and he based this off of the work of Vladimir Janda, a very respected, actually MD, but has contributed a lot to the rehabilitation field after he got polio. And Michael created this clinician rehabilitation pyramid, and I think it's very, very well done. So let me orient you to it. When a patient comes in to see a therapist after they've been screened, they're going to fall somewhere on this pyramid. Many times, we're going to see the patient in pain. So they'll start at the bottom of the pyramid. They'll come with low back pain. They're in pain. They're inflamed. We need to work from pain, and we need to, with a variety of different steps, which we'll go into, we need to work the patient from pain, out of pain, and move them up to learning a skill so that they're able to move without pain. So they work through this pyramid from the bottom up. Sometimes patients come in and they're in that red zone. Sometimes patients come in and they're in the orange zone. Typically, we don't see patients in there if they're already in the light yellow or blue zone. All right, so here I'm now going to overlap 2 different models, again, to just orient you to how many therapists think. Again, I'm not speaking for everyone, but many therapists may share this viewpoint. So on the bottom, we have that pyramid that you just saw. Okay, On the top here, we're taking a secondary framework from the treatment-based classification system. What the treatment-based classification system says is that low back pain has numerous different contributing factors. It involves biobehavioral influences, that's at the top, and socio-occupational influences. Those need to be addressed. Again, that's almost a whole different talk, but those need to be addressed. What else is involved in low back pain is the nervous system, soft tissue, and joint. We consider that mobility issues, and then stability issues, or how your muscles are creating stability for the spine, the strength, and those muscles then need to work through an activation, acquisition, and assimilation. Long story short, all of those words in the middle of the page contribute to low back pain. We're going to break them in half. So we're going to focus on local mobility, which we need to treat first, and you'll see why. And then, as therapists, and sometimes in conjunction with special cases, but then we also need to work on global stability. If you see the local mobility, that needs to be treated first. We tend to see that when patients are in this red zone on the pyramid. So we need to get their motion up before we can many times move them up the pyramid. And then as we work on their muscular strength, stability, work them into certain movement patterns, that's worked into the top half of the pyramid. So we're addressing these issues a little bit further on down the pyramid. So local mobility, and this is a very generalization, but local mobility down here, we're addressing that first. And then as a patient's getting better and moving up the pyramid, we're working on the stability component. All right, so local mobility. This is the whole goal, is we need to normalize motion in nervous tissue, joint, and soft tissue in order to normalize movement. So a good example of this would be you have your neck has been, or that's not your neck, we need to talk about low back. So your low back is killing you. And I do an assessment on you, and I go through that whole regional interdependence concept. And what I see is you move well everywhere except for your right hip. Your right hip doesn't move well. Until I correct that right hip mobility restriction, I will not be able to train the right movement pattern because you don't have enough motion to do that movement. So I need to get rid of that mobility restriction so then I can train you the right way. Okay. Ooh. Admitting people. So the goals of local mobility is we provide an intervention that many times provides temporary tissue changes and pain relief to normalize movement. All right, so if it's a soft tissue issue, if you come to me and say one of the things that is limiting your lower body movement is because your muscles are too tight, or you have a trigger point, or they're too stiff. There's lots of different versions that we use. What do we do as therapists? Well, we can use that whole list. What I need to do as a therapist is use one of those techniques to accomplish the goal of mobilizing your tissue so that you can move better. Okay? But what if it's not the soft tissue? What if it's not the muscle? What if it's not the fascia? What if it's a joint? Like I said, what if it's your hip joint is not moving well? Well, what do you do then? Massage isn't going to work because it's a joint. You need to get the joint to move. So we can do a mix of things. We can use active assisted range of motion, meaning I teach you how to mobilize yourself, like in the bottom right-hand photo, or maybe I need to do it for you. And that's more of a passive mobilization technique. So if the joint's locked up, those are the type of techniques I would use as a therapist. All right, well, there's a third type of tissue that a lot of people forget, but it's the nervous tissue. So if you've had, for example, a herniated disc, many times that sciatic nerve, because many times the disc protrusion is at that L5S1 region, it's going to press on that sciatic nerve, and sometimes that's going to piss off the nerve. And the nerve needs to be mobilized. Now, the nervous system is very temperamental, and it needs to be implemented at the right time, or it can kind of flare you up. But in general, if your nerve is flaring up and it's restricted in motion, these are some of the techniques that we use to get a nervous tissue to move. So remember, the bottom line is that in those two paradigms that we paired, you have to treat motion first, or at least start motion first, even if you're working concurrently, but you need to address mobility deficits in order to train appropriate movement. And training appropriate movement ultimately leads to less pain. All right, so we've worked someone out of the bottom stages. All their mobility is cleared up. We've taught them stretches, we've taught them soft tissue, we've taught them nerve glide, we've normalized how the body is supposed to move. Now we need to take into account how the muscles function, because if we don't address that, that's also going to be a problem. This is kind of in this framework. It's called global stability. Okay. So the first part of this global stability from the treatment-based classification guideline is called activation. It's as simple as getting the right muscle to activate at the right time. The video is courtesy of my colleague here at Stanford Therapy as well. I got to add that on the slide. But activation says, okay, glute muscle, I need you to fire at the right time. So if you watch this video, possibly to the untrained eye, you're not going to see much, but as therapists, what I see is that in order to lift her leg, she's using her back muscles. She's not using her butt muscles. She's really not tapping into her hamstring muscles. She's using her back to lift her leg. And over time, that very poor movement pattern is going to lead to chronic dysfunction, movement dysfunction, and probably some pain. So, let's pretend this patient, their goal is to actually to complete a deadlift or a power clean, okay? So the first thing we need to do is we've already cleared out all their mobility restrictions. Now we need to train the muscle. To do a power clean, you need a lot of appropriate glute activation. We need that glute to fire more than the back fires. All right, we accomplished that task. What do we do next? Now we move into acquisition. That means we need to train appropriate coordination of movement. So now, instead of lying on the table and very much isolating just the glutes and a little bit of the hamstrings, we say, okay, now you're in a standing position. When you stand up from this hip hinge, right at this point, that's when your butt should fire. Many times people's glutes don't fire at that point. So we need to now train this movement. We're training the coordination of a movement pattern. This is called acquisition. And then finally, we have assimilation. That's where we apply coordinated movement to a functional skill, the very top of the pyramid, so to speak. They've worked through their mobility restrictions. Now their glute fires. They can do a basic movement pattern without extra load. Now you add the complex movement, and now you add the complex mode, and you put it all together. So theoretically, the patient should be feeling good with this. They really shouldn't have that much back pain if it's a simple case. And in this case, I'm picking a very simple case without significant comorbidities or psychosocial history. But that's kind of the framework of it. Many times, and with different muscle groups, patients slide all the time back and forth they slide between global stability deficits and between mobility deficits. So it's very common, or maybe you came in and you worked on mobility for a couple sessions, you got up into the green global stability, you're higher up on the pyramid, something aggravated you, now you're not moving the right way, and you slide back down to we need to work on your motion now. So it's very common for patients to go up and down, but generally we want them going up that pyramid, taking 2 or 3 steps forward, maybe 1 step back. All right. All right, so big takeaway. again, I'm talking mostly about biomechanical based low back pain. Not in this lecture specifically, I'm not taking into account a lot of the psychosocial factors. But typically, low back pain is resolved, appropriately managed, or reduced if the following steps are taken. First, you got to use those different frameworks in the literature and your clinical experience to create an appropriate PT diagnosis. Then you have to address psychosocial factors if they're there, maybe with the help of other allied health professionals. You should, in a grand scheme, be treating mobility restrictions first. And then once the patient's joint, nervous system, and muscle tissue moves well, then you need to teach the whole body to move correctly and when the muscles work appropriately and have enough strength. All right, so that kind of puts it all together again. All right, so that's what's been going on so far. All right, so how do we collaborate now? That's the big thing. So like I said, a patient very likely can scroll up and down this pyramid with numerous different body issues from ankle, knee, hip, and then all of those different joints can affect the low back pain. Where do I need help from different providers? A great example would be someone comes in and they have sciatic pain. Really, really bad sciatic pain. It's been under control for the last couple of years, but maybe they went on a really long bike ride. They were in a bent over position, and then you're pedaling with the pedals. That's a really big irritability factor for a lot of those sciatic nerves. They're so irritable that I can't touch them. If they're that irritable, I need help. I actually need to say, hey, MD, I think they would benefit from a cortisone injection or a dose pack, a corticosteroid dose pack. Or just, can you prescribe them over-the-counter anti-inflammatory for 2 weeks? I can't do that as a therapist. And if I need to get someone out of that acute pain in order to help them move up the pyramid, I need help with that. Another really good example would be a patient's doing really, really well. We got them out of back pain, they're moving well, they have the right lifting mechanics, they got the right biomechanics, and they're like, okay, I want to go back to yoga, or I want to go back to a personal trainer. I say, okay, great, go for it. And so this is where we need the help of really great yoga instructors or personal trainers who understand where physical therapists are coming from to then take our patients and push them into moving appropriately at that top of that pyramid. Similarly, in other ways you can get involved. So say a patient is low back pain, a lot of fascial restriction, a lot of mobility restrictions. There are a lot of techniques I use as a therapist: soft tissue, joint, grade 5 joint mobilization. I can't dry needle in California. I can't do acupuncture. And a lot of times that's very beneficial to get rid of mobility restrictions so that a patient can move up that chart. I need an acupuncturist, or I'm trying to get someone to build strength. And I can give them the right sets, sets and reps, the right load, but if their nutrition isn't on point, they're not going to build muscle, and we're going to stall in this rehabilitation pyramid. We can't move them up or down. So maybe I need the help of a nutritionist. So that if we're really taking a holistic approach to low back pain to a patient, I need help throughout this entire pyramid so that these patients are getting better, and we need to collaborate on that. All right. So this is my shameless plug, so to speak, as Emily stated. Recently I founded PhysioCare. We're specifically focused on primary care for women's movement health. And what I just spoke about is we are trying to create an environment based off of a physical movement approach. But I want to create a group where I have my females come in, I assess their movement, and then if I need help with their nutrition, if I need help with mental health, with anxiety, if they need medical interventions or a specific medical doctor to prescribe or image things that I can't do. I am trying to create this framework for people. So my little shameless plug there, if you're interested, you can message me later. And the idea is that our role as physio care is to take an exam, create a movement profile, implement a prescription so that the patient and the client knows what to do. We use healthcare technology to track those gains, and then we follow up with them virtually, and we can go from there. Okay, these are all my citations, so you can go back and take a look at those, and that's where we're at. We're done for now. So what I'm going to do is I'm going to unmute everyone for the second, and then please keep yourself muted, and then we're going to kind of go into a little bit of a panel discussion here. Or hold on, I'm just going to unmute two people. I'm learning. Emily. Ah.
Hi. I can unmute myself, so yeah.
Okay, I'm sorry.
Cool. So,
all right, Emily, go for it.
Yeah, we'll jump into the mini panel, and then we'll do a Q&A. So I'll start. As I mentioned in the beginning, I just in the midst of graduating as a family nurse practitioner, but most of my experience is in primary care and community health. And Lauren, I thought that was awesome. It was a great presentation, and it was a really broad topic, but I felt like I learned a lot, and I have some awesome models and frameworks I'm going to look at and take to my practice. So a lot of what I do in primary care is trying to get people to go to physical therapy and to do physical therapy exercises at home. And I really work on addressing the psychosocial factors that you mentioned. So my question that I'm interested in asking is, what do you think I should know as a primary care provider? What do you think I could do better? What do you see primary care providers doing that you wish they could do better?
Yeah.
Well,
first of all, I think primary care providers have a really hard job, and I applaud all primary care providers because you're literally dealing with the entire body, and many times you have 15 minutes to work with every single system in someone's body. So putting that I think it's important to put that in perspective, because you guys a lot of times have 15 or 20 minutes and you're back to back to back, and you're seeing people with a lot of stuff going on. In my profession, and it's different for every clinic, but some clinics range from 30 minutes, but I'm lucky enough to have 45 minutes with someone just to look at their musculoskeletal system. So one, I just want to put that in that framework. So as I don't expect PCPs, honestly, to have the time to go as in depth of a screen as I have the luxury to do. But would be really helpful is if you are able to use simple tools like that start back tool to catch those yellow people and you send them to us. That's really helpful. Or if you're just oh, this is a 20-year-old guy who just lifted something really heavy, it's axial, if you just give him 4 weeks, he'll be fine, and most likely he will be, and don't send him to us, then we as therapists won't be overloaded. So just kind of knowing how to subgroup those patients real quickly. Similarly, if you notice a patient is catastrophizing, they're saying things like, I hurt my back 5 years ago and that's why I'm not able to go back to work. Or I'm afraid to pick up my daughter because I'm afraid it's going to hurt my back. Big triggers like that, those are actually really good to send to us. Because you might not have the time to sit down and say, this is okay, this is what mechanically is going on. They do really well with therapists. Specifically, and not all regions have this, we're lucky here at Stanford, we actually have a pain management clinic that works with physical therapy, the medical doctors, psychology, and those are the type of patients we send there, because then we can address their back pain from a multifactorial approach. So the bottom line is just if you can kind of subgroup the type of patient they are, and then if you're able to send them into the optimal location, if they're appropriate for normal orthopedic physical therapy, or this is someone with a lot of fear avoidance and a lot of anxiety, they probably need to go to pain psychology first, and then they need to go to physical therapy. Or if it's someone who it'll get better on their own with maybe a quick muscle relaxant and rest, don't send them to us. And that would be really helpful.
Awesome. That was super helpful. Thank you. And I also want to mention I'm also a registered yoga teacher. So a lot of that was just like applicable to, both of my passions. And I learned a bit about the regional interdependence piece. I have my whole, I'm taking notes over here.
I love it.
And I just, sorry, about the local mobility and the global stability. In yoga, we talk a lot about the balance of having mobility and stability as being sort of the optimal sort of goal. So just thought I'd mention that.
That's awesome. Yeah, it translates across a lot of realms because it's just a concept that fits into pretty much all movement categories. The one point I wanted to make is the frameworks I'm saying work really well for the traditional approach to therapy. I did want to point out, just so I'm not throwing our other sports-based physical therapists under the rug by accident, that if it is a young guy with a lifting mechanics issue and you don't send them the physical therapy, that's probably fine. But if you do, a lot of therapists, especially the sports-based specialties, really like to see those green zone patients because they can work on performance and they can work on appropriate lifting techniques and maybe even prevent a back injury later on down the road. So the perspective I'm taking from, honestly, if I'm being realistic, is a healthcare system that is sometimes overloaded with a lot of patients and that we can't take in everyone. But there are a lot of private clinics that are sports-based physical therapists that interact with personal trainers. They want those green box patients. So just getting to know your community, what's out there, what the patient is looking for, and knowing that physical therapists can kind of do both zones, so to speak. Yeah.
Katie, you want to say your piece?
Oh, I was muted, sorry. Yeah, so I have a couple questions for Lauren, and then what we're gonna do after we go through this part, we're gonna then open it up to the rest of the people that are currently on the call. I know we have a couple people already in the chat box that have some questions to specifically ask for Lauren, so I'll keep my part very, very short. But I was a CNA first when I was 17, and then I got into nursing, so I've been around for the block a little bit and even had my own back injury from a range of motion nursing patient issue. So I can very much relate to 9 months of physical therapy with a low back pain injury. So one of the things that jumped out at me were a couple pieces, Lauren. What are your thoughts on, what could you say to other providers besides Emily about maybe the appropriate way to refer? Because I think from what you said and just from being in practice, maybe providers don't know that PTs specialize in so many different avenues. So do you have any guidance on that?
Yeah, I think this has been one of my missions to get what we do as therapists out there, so to speak. So it really comes down to knowing your community, in all honesty, and what resources are available, which I know is really hard as a healthcare provider because you're already seeing a big caseload and it's hard after a long day to then go figure out what's in your community unless they kind of come to you. But again, those examples, keeping in mind that if a patient comes to you and they're more athletic, sports-based, they just hurt their back, it was acute. Like I said, they may and most likely will get better on their own, but they could very well benefit from seeing a sports-specific training therapist or an orthopedic-based therapist. Or if they're a dancer, like I know we have a PT on here that works with dancers, know about that resource and send that patient to the physical therapist that specializes in dancing. And vice versa, if someone comes in and they're very fear avoidant, high anxiety, catastrophizing, it might not be the best idea to send that patient to a sports clinic because they might not be taking the best approach for that patient. The therapist should be aware of it, and a lot of our therapists are amazing and able to kind of code switch between types of treatment they provide based on the patients they get. But long story short, read the patient you have in front of you, know their goals and expectations, and then kind of feel out your community resources and see what your therapists in your area specialize in.
That's really helpful. Thanks. There's another thing that you had said during your presentation about the mindset, how physical therapists may think very different from providers and other health professionals. And I think you are absolutely spot on with that, because at least through the nursing curriculum in the profession, we're very much based on range of motion and body mechanics and how to do proper techniques of transfers and things. But the curriculum currently does not go into this type of depth, and I do think that it would probably be much more helpful. We're very much more reactive, like, oh, that really hurt, I shouldn't have done that. So I do think for me personally, I can bring this back, put this in the back of my head of when I have conversations with other nursing professionals. If they have ever bring up, the role of the PT or some things we can do about injuries, I can specifically say from this presentation, this idea about that framework of, patho versus the kinetics. So thank you for that.
Awesome.
And the last point I'm going to make before we can open it up to the chat box is with your physio care, which obviously I'm biased and loving and watching you build and grow this. One of the key things I think that this may relate is, have you seen in your practice, or do you expect to see in your practice, a lot of pregnant women or women who have gone through labor and birth coming in with low back pain that is going to be like maybe a trend for specific types of care down the road, or is it care now?
Really good question. So there is so I'll start with the first part. So right now, the physical therapist, American Physical Therapy, has a specialization in women's health. And what that is basically, and again, the terminology might not always be appropriate for where we're at in today's world. Maybe it should be pelvic health or such. And we definitely have to work on that as a profession. But right now, it's named women's health. And what they focus on is pelvic health. So a lot of times after you give birth, after you give birth, that area is not functioning the right way. And we have therapists that specialize in that area. We actually have one listening in today. So maybe she can sign in later, or I can give you her contacts if you need it. But they specialize in working in that area, and they get very detailed into what they do. So there is specialty in that already. Women's health sees men also. It's really kind of more pelvic floor dysfunction and such. So maybe the name will be changed eventually. But that's what we have available now. As for your question as to physio care, because what I'm doing is primarily working with women. That's just a personal passion of mine. I love you guys, but I really like working with my ladies, and I think that the mechanics are really interesting, and I work really closely with women's health specialists or pelvic health specialists. And yeah, I actually think, and we're still pilot testing right now, but I think postpartum mothers are going to be a big population we see, because after you give birth, whether it's a C-section or a vaginal delivery, your body's been through a lot. And so you do need rehab. And actually in a lot of other countries, it's normal it's part of practice. A woman gives birth and they go to physical therapy. It's a norm. It's cause and effect. But they don't do that here in the States, which is kind of sad. But I'm hoping that I can work with a lot of new moms.
Mm-hmm. Great, thanks. That's all I have for questions, and my take is, so if anyone wants to ask me any questions about nursing stuff, but this is
cool.
So, and Emily about nursing stuff.
Awesome. Well, if anyone wants to ask a question, if you're shy and want to add it into the chat box, you can type it in there. We'll field it.
Already.
Oh, okay. I don't see them, so you go for it.
There is a question. I don't know if my father wants to ask himself, but yes, my father's on this call and he has added a question to the chat box.
Oh, okay, good.
So basically, I don't know, Dad, if you want to talk, but 50 years ago when he was a freshman, he learned that his L3 has a deformity in it, and it's in the chat box, Dad.
Oh, I see it now.
Thanks for ratting me out.
It's public.
Hey, Lauren.
Hi, Mr. Robinson.
Oh, nice to see you.
How you doing?
Doing so well. So when I was in 8th or 9th grade, I developed a deficiency in L3. And I was told it was because of a calcium deficiency. And my L3 never grew. And it is that way today. And I have a limp on my right side as a result of that. So when I do something stupid that I know I shouldn't do, I have a cervical brace, one of those $100 ones with the metal things in it.
Mm-hmm.
Is there something that I could do or exercises that I could do that would help me in the long run so that I could somewhat, other than lose my gut, because I'm sure that has a big deal to do with it, to help me, Katie, help me correct that?
Yeah, Mr. Robinson, you're gonna hate my answer right now, but because I can't formally take you in as a patient, I can't give you medical advice right now, because like we talked about, there's a lot of stuff going on, a lot of things I'd want to screen, joint mobility, movements. So I don't want to just make an assumption based off of the couple sentences you just gave me. So
that's an honest answer, and I appreciate that.
I'm gonna have to say you should see a physical therapist.
Well, maybe I'll see you in a little while, one of these days.
Yeah, definitely. I'd be happy to do it officially and professionally, but I can't give you that right now. I'm sorry.
No, thank you so much.
You're welcome.
Congratulations to you. Super job.
Thank you.
You too, Katie. And Emily.
Thank you.
Constance, I see you have something in the chat box here. Do you want to talk?
I'd love to see everybody's faces if you want to turn on your videos.
Yes.
Yeah, it's nice to see people's faces.
Let's see. She might be working on something else as well. Constance, you there? All right. Well, basically, I'll read what she wrote. Oh, okay. She's having an issue with the mic. I can unmic you. Did that work, Constance? Sorry, guys. Yes, I can hear you.
Addresses a lot of times an acute pain issue. So something that you mentioned in your presentation, which is fantastic, is the different phases of when you should be treating a patient, when it's appropriate for PT to see a patient, et cetera. And so by integrating a PT in the primary care clinic, a lot of times it eases the burden that is associated with primary care physicians having to see so many patients. And a lot of times when they do see it can be an ankle sprain, it can be a low back pain problem, they don't necessarily have, an hour to spend with a patient to really fully assess. They'll immediately refer out for an x-ray because that's the safest option to do. You want to make sure that there aren't fractures or something like that. But a lot of times that imaging isn't necessarily necessary right away. There's a lot of other questions, a lot of things that PTs do in our examination that may say that, hey, we don't need to take that picture right now. That's not something that's warranted. And as a result, so the PCP can immediately send the patient off to go see a PT. So the PT has their own office. It's just like a typical primary care physician. You just go in, and so a lot of times they can see that patient right away, which is really awesome. The patient feels like their issue is immediately addressed, so their patient satisfaction is significantly increased, and you're addressing the problem a lot earlier on, which is fantastic. And I think right now this is only in military practices, and as I said, VA that we're seeing this, but I think Stanford, it would be a fantastic place to be able to integrate something like this. And I'd love to see it, across different boards as well as, an emergency room. And I don't know if you want to put your own sense into this, but I think this is something that we need to see more of in terms of this fluidity rather than this very rigid structure where you only see one discipline and then you have to wait 3 weeks to see another discipline. Like, it would be really fantastic if, you go in and you're able to kind of bounce between a couple different practitioners and those practitioners collaborate, which you're definitely talking about, which is fantastic.
Yeah, so that is great. Everyone, Constance is actually a physical therapist in the Bay Area here. So that's her background. But Constance, I completely 100% agree. And I wish that was the current structure of the healthcare system. It's not. You're right, the military has done a lot of great work because they have that flexibility. But I think as people are getting sicker and as healthcare costs rise, we're not getting these people better. And we're going to have to do an interdisciplinary approach, or we're just going to lose a lot of money. And we're going to have to use tech to help track this, because we can't just have everyone come into the clinic, especially with COVID. Now that we're kind of getting more to primary care approach. Yeah. Awesome. I got a message from Lucia, put it in the chat box for everyone. Lucia is the women's health, or maybe we should call it pelvic health specialist, that she works here with me here at Stanford Healthcare. She also has a practice of her own as well. So if you have specific questions about pelvic health, bowel, bladder, sexual dysfunction, things like that, and you're in the Bay Area, if you want to check the chat box, you can talk to her there too. Yes. All right.
So thanks.
Oh. Oops.
Hi, I'm Caitlin. I'm an athletic trainer. I actually work in optimization of the human weapon system with the Vermont Air National Guard. And a lot of what I do is I'm actually working with the pilots, the fighter pilots, to try and prevent back injuries, because there's a lot of research about the strain that G pushes on their backs. We do a pre-flight routine to kind of warm up their backs, and afterwards we will ice them down. So kind of more like an athlete driven perspective. But is there, and I'll do appointments, like one-on-one appointments to address specific issues, but are there certain things that you would suggest people be working on, not necessarily specifically pilots, but be working on before their backs get injured to kind of prevent future problems?
Great question. First of all, that is a really cool job. And you probably have a lot of knowledge about that I have no idea about. I did not know about that. So kudos to you. In terms of just generally, the way I like to think about like preventative approaches, I can take it in two routes. So if we're talking about your patients, your clients, they're an athlete. That's basically how I would think of them. And like you said it yourself, you're doing an athletic-based training system. So taking into account your patient's goals to prevent injury is important. So if they're going to be under high load, high stress, G's on their back, you're not going to train them with a 30-second plank. Like, that's just, it's not going to be enough, right? You can't even condition the tissues to take on that much load. So I don't know what you're doing. I'm sure it's an amazing program with your background. But taking into a patient's goals, their activities, what they want to do, and then training them for that. If you want to be a marathon runner, I can't just have you do 10 squats and say you're strong. Okay, go run 7 times your body weight over and over and over again. That's going to get knee pain, back pain. Again, I'm getting off of back pain, but spine pain is usually in the middle of everything. So the first answer to the question is, take into account your clients' and your patients' goals and then train them at the intensity that they need to accomplish that goal. If you're training a dancer, they need to be very flexible and very strong or they're going to have back pain. But if you're training just someone, an older woman who just wants to walk around the block a couple times and stay out of pain, then you want to make sure she has enough hip range of motion. You're going to want enough, she has ankle motion. You're going to want to have a general strength tone in her legs and her abs and her butt. And then the 30-second plank might be perfect for her. Wall squats are going to be great for her. That's going to get her moving. So it depends on their activity level. As an average kind of response to what you would do for the average relatively athletic person, there's Stuart McGill up in Canada, has a big researcher on low back pain, and he has kind of the McGill Big 3 exercises, or just general core stability exercises, your planks, your side planks, your dead bugs, your bird dog, stuff like that is really great. The other part for just general low back pain maintenance, along with that core stability, which everyone's actually pretty good at when you think of low back pain, is a lot of people forget about that mobility component. So if your hips are stiff from sitting all day, or if you don't really move through your full spinal articulation on a regular basis, you're going to be stiff and it's going to hurt. So a long answer. Train the patient or client for what they're going to do. If they're an athlete, train them like an athlete. And if just general concepts is specifically for the low back, because it's literally in the middle of your body, you have to be mobile and you have to stay strong and you have to have a nice core. And that usually will prevent a lot of the aches and pains. Awesome.
Awesome. Thank you.
You're welcome. All right. Anyone else have some questions for us?
I have a question. I'm Alyssa. Lauren's one of my best friends from high school. So this was a really awesome presentation. I think you did a really good job, completely objectively, but really. Professionally, I'm a dentist and I focus on treating adults with disabilities and also older adults in nursing homes. So for a lot of my patients have a difficulty in tolerating dental treatment, as most people may think. So we have a lot of adaptations we have to do. And that results in me providing a lot of treatment not ergonomically. So as a result, I've definitely had some chronic lower back issues. So this is a really relevant topic. So my question is, I'm curious about your input on telehealth and its role and how it fits into what you're discussing, especially thinking about trying to get PT access to maybe populations who are lower resource or whatever area that are having issues getting access to that care, including in the context of COVID. Yeah.
That's a really great question. And then I also know your background is that you're very interested in public health. You're doing your MPH right now at Harvard. Woo! So what I would say, my take on telehealth, we've had to implement it because of COVID here. And so we were kind of just thrown into it. Theoretically, it's something that I've always wanted to do. And then when COVID hit, I had to do it. What I've been finding just from my limited clinical experience over the past few weeks is that it works really, really well for some patients, and it's not great for other patients. Specifically, just kind of general trends, this is my own personal opinion that I'm seeing, is patients like post-ops, which were stopped, but post-operative care and patients with a lot of joint restrictions, tissue restrictions, nervous restrictions, that joint mobility deficits, those patients, they're really hard to treat via telehealth. Though, because someone needs to get in there and like first assess what's locked up or not moving, because the patient might not know the norms. And so they might need someone to go get those mobility restrictions first worked out. So telehealth hasn't been working wonderfully for that. But the patients that it does work really well for is I have a couple of new moms, actually. And you were talking about access because they have kids and they don't want to leave the kids and they don't want to expose the family to COVID in this environment. And it's a general assumption, but it applies to most. So a lot of new moms, they have a lot of laxity in their tendons and ligaments because the estrogen and the relaxin produced through birth, especially if they're breastfeeding. So it's safe to say that they don't have mobility restrictions. Like they move too much. So knowing that as a therapist, I say, okay, it's a close assumption that mobility restrictions don't really need to, we don't need to address those. It's mostly TheraX-based, mostly exercise-based, mostly core stabilization type stuff. And the patients who are mostly exercise-based, or I'm fixing their movement pattern, or I'm working on their balance, telehealth has been working really, really well. So if I boil it down, if I were to like blow this up to improve access for everyone to PT, if we were able to discern like, hey, they've got some significant mobility restrictions, go see chiropractor, go see a traditional PT, go see a massage therapist down the road, get everything loosened up, then jump on the call with me. And then I can show you the right movement patterns, the right exercises to then train that movement. I think that's a very valuable option. That's just my clinical experience. So I'm hoping that it'll get up and running. Kaiser actually uses telehealth around here as more of a screening of their patients to make sure they're going the right places or if they're appropriate for PT. But in terms of like telehealth-based PT, I think it has a lot of promise, and I think it can be used really well, especially if you have a network of local providers that you can like work with. Yeah. Thanks, Liz. That was a great question.
Thanks, Lauren, for the excellent answer.
I like your glasses. They remind me of someone.
We have another chat box.
Perfect. Okay, this one's from Johanna. She is involved in the healthcare system and aging. She's actually a lawyer, so she has the ability to work in like healthcare law, which is a really interesting perspective. Her question is, how do you see the practice evolving as women age, dealing with osteoporosis and other muscle loss? Oh, I love that question. That's my bread and butter question. So yeah, one of the reasons I really like working with women is because we're pretty complex. So as we age, specifically for women, if that's like how you were born as a female, we're going to go through natural hormonal progressions. Unfortunately, when we go through menopause, we lose a lot of the hormones, a lot of estrogen and progesterone, and that's very protective for women in terms of building strength and protecting our bone density. We know that as soon as a woman goes through menopause, that bone density is going to drop. They've got a high risk of osteoporosis, and so that's something that men don't necessarily need to deal with. So in terms of conservative management, how to address that, it's really, really important to educate women, especially postmenopausal women, the importance of strength training, because you're going to lose muscle mass. There's no way around it, and you have to maintain it. Otherwise, you're going to get weaker and weaker and weaker. The other thing is with bone density from a conservative perspective, again, there's medications you can go on, but that's one way. But from a conservative perspective, what they found is to work to decrease that osteoporotic effect, loading. And I'm talking about like hard jumping, loading, lifting. Like if I could get a 70-year-old woman bench pressing and squatting weights safely, and they miraculously had like a perfect cardiovascular system, they didn't have osteoporosis. If I could get that woman lifting, I would. So the sooner that we tell women that this stuff is gonna happen to you, there's really no way around it just because of our metabolism, our hormonal system, and you say, okay, when you're starting menopause, you need to start weightlifting, because if you get it, you have osteoporosis, or you get a fracture, a stress fracture, or you lose all of your muscle mass, we can still train that, but you have to go much slower. You have to be much more careful. But if we're able to say, hey, you're 50, you need to start strength training for your own hormonal balance to prevent osteoporosis and to maintain your muscle mass, we need to get that education out there. So the question was, how do you see the practice evolving as women age? Is we need to get the information out sooner, and we kind of need to make it a big deal, because it's kind of like, women get in shape because they want to look good, but like, excuse my likes. But no, if you don't get strong and if you don't regularly load your bones, you're going to end up with a stress fracture. And then we know if you're getting up to your 60s, 70s, you get that hip fracture, 60s, 70s, 80s, that's a high mortality rate. And if we can just stop that cycle by talking to women in their 40s and 50s, that's what I want to see. That was my soapbox. Yeah. Thank you for that question, Johanna. Okay, we want to be respectful of your time. It's coming down to 5:30. Well, it's 8:30 on your side, most of you. So Emily and Katie, you want to wrap it up?
Oh, Katie, you're muted.
You go first. I'm going to find the post survey link.
Oh, okay. Well, I just want to thank everybody for coming. That was awesome. And thank you, Lauren. That was just a great presentation. And just like I said, it's a really big topic to tackle. And I think you did a great job. I learned a lot, and just sort of started a lot of thought processes for me. So we do have a post survey. We do have a post survey. So we'll be sending that out in the, it's in the chat box now. If you can fill that out, that'd be super helpful. We'd love to learn like what you liked, what you didn't like. I'm sure this is our first meeting. So yeah, it'd be great to hear.
Great job, Lauren. Thank you. And thank you to Emily as well. This is our first partnership, our first webinar, and we're so excited to see your feedback, and we're hoping for the second, third, fourth, fifth to come. So if you're interested in being a speaker, definitely on the survey, there's a contact information, and we will get back to you and we can set that up.
Yes. Thanks, guys. Appreciate it. Stay safe and healthy, and I love to see all your faces. And this PowerPoint and the references and the slides will actually be on our website. We'll post it there because we're going to try to create a reference point of all of our speakers and their contacts, so you can reach out to us there as well.
See you next time.
Bye.